Good morning. Thank you for this opportunity to present on the prevention of sudden cardiac death in athletes. My name is John Drezner. I'm a team physician here in Seattle, Washington. Take care of the Seattle Seahawks, Seattle Reign, and some of our university athletes. I'm also the director of the UW Medicine Center for Sports Cardiology. These are my disclosures. I work with a couple companies and advise on ECG interpretation in the young. I'm currently editor-in-chief of the British Journal of Sports Medicine, and we'll see some papers from that journal. I volunteer for several local or national foundations dedicated to the prevention of sudden death in the young, and have research funding from the National Center for Catastrophic Sports Injury Research and the American Heart Association. We're all aware of some of the high-profile cases of sudden cardiac arrest that have occurred, cases like Christian Eriksen, Damar Hamlin, Bronny James. But as we know, it's not just our high profile and professional athletes who can have sudden cardiac arrest. SCA is the leading cause of sudden death during sports and exercise can be a trigger for sudden cardiac arrest in athletes with an underlying heart condition. A quick stat from our data, 75% of all fatalities during sports are cardiovascular related. So, as a primary care sports medicine physician responsible for the health and safety of athletes, this is really my first and most important responsibility. As I reflect on the field over the last 20, 30 years, for me, sudden cardiac death in athletes really came to the forefront when I was at university and also in medical school with several high profile, sudden death cases. It's really important to think what we've learned since that time. Sudden cardiac arrest is not so rare, not like I learned when I was in medical school. The history and physical is simply not enough for cardiovascular screening, and precision ECG interpretation is possible. AED should be everywhere, yet still sudden cardiac arrest can go unrecognized. So this is the outline of what I'd like to cover. I think we need to talk a little bit about the epidemiology of sudden cardiac arrest and death in athletes. We'll talk some on cardiovascular screening and ECG interpretation, review emergency preparedness and survival outcomes from SCA over the last 2 decades, spend some time on recognition and management of sudden cardiac arrest, and end just discussing some of the gaps to improve survival. I really like this figure published in 2013 by Andre Lagurch, which just summarizes the age-dependent incidence and causes of sudden cardiac death in athletes. In blue are the ion channel disorders, in the darker orange, the cardiomyopathies, which really represent the majority of cases for individuals under the age of 30 or 35. And beyond that, really, coronary artery atherosclerosis is the leading cause. This is a study we published in 2020 looking at 4 years, 2014 to 2018, all cases of sudden cardiac arrest and death in U.S. athletes. You can see the wide variety of different conditions that can lead to sudden cardiac arrest, cardiomyopathies, electrical disturbances, even acquired disorders. There's really quite the heterogeneity. It makes screening more difficult. Looking at the most common causes of sudden cardiac arrest and death, it's also somewhat age-related. So for cardiomyopathies overall, there's about 20% of that cohort. But in our college and professional athletes, it represented 47%. An entity like an anomalous coronary artery, something that would not be identified by an electrocardiogram, only 12% overall in our cohort, but in our young adolescents, our middle school athletes, this was the leading cause of sudden cardiac arrest and death in the US, almost a third of those cases. And so for the physicians in the room who are evaluating young athletes with complaints of exertional syncope or exertional chest pain, anomalous coronary artery is something you have to rule out with imaging, probably beginning with an echocardiogram, and if there's any uncertainty, a CTA. This is work that's been presented before, but is still unpublished. The incidence of sudden cardiac arrest and death in the NCA over 9 years, the multimodal sort of approach to identify cases, including a more recent survey of each institution. The overall incidence of sudden cardiac arrest was 1 in 45,000, but we know it's more common in certain populations. It seems to be about 4 times more common in our male athletes. Black athletes, for reasons we're not certain about, have a higher incidence than our white athletes. And if I take you to the top right of the screen, If you're an NCAA Division One male black basketball player, your risk was 1 in 1,600 per year. If we look at the etiology of these cases in men's basketball, 62% were from cardiomyopathy, and a total of about 69% were potentially ECG detectable. And so, if you're caring for a men's basketball team in NCAA and you're not providing advanced cardiovascular screening, I don't think at this point you can say you're providing the standard of care. Cardiovascular screening in athletes has been something that's been a challenge and debated for a long time. We all agree it's important. We all agree that the purpose is early detection of conditions at risk, and we want an evidence-based approach. So, which of these tools is enough, the PPE monograph or the AHA 14 point? And I think you know my answer that really neither. Neither is enough if your intent is really to identify people before there's a problem. Zero. There is zero validation of these history questionnaires and zero studies that show screening by history and physical alone either effectively identifies individuals at risk or prevents sudden death. 20%, 20% false positive response on those history questionnaires at a minimum, and only about 20% of athletes who go on to have sudden cardiac arrest have warning symptoms. So if our evaluation is based on identifying athletes who have potential warning symptoms, we've already missed the majority of individuals at risk. We started screening with ECG routinely in 2010 at the University of Washington. This was just our initial cohort, 800 athletes. You can see that 37% had a positive history response, 3.5% a positive physical exam like a murmur, and only 2.8% back then considered an abnormal ECG. We identified 5 individuals with conditions at risk for sudden death, one with HCM, one with long QT, and 3 with WPW, all identified because of use of an ECG. If we had done history and physical alone, we would have missed all of those cases. Kim Harmon has done great work in this field, and this was a systematic review and meta-analysis published in 2015. Over 47,000 athletes included. ECG was 5 times more sensitive than history, 10 times more sensitive than physical exam. A lot of times we're asking, like, when do we start cardiovascular screening? Recommendations are generally, starting at age 12 and every 2 years after that. But when should we really be doing it? And this was a really a terrific study from our Italian colleagues, a cohort of 22,000 young athletes who had serial investigations, including ECG. And you can see that after the age 11, beginning about age 12, was when the yield really picked up. The yield for cardiovascular screening increased, and that's probably because of the phenotypic expression of some of the conditions that we're looking for that occurs during adolescence. So in the US, we continue to have this big gap. On one side is generally what's occurring for high school and younger athletes, just a history and physical model, often with the primary care physician. And on the right of the screen is really what's considered best practice, history, physical, ECG well interpreted, and cardiology resources to help with downstream investigations. And this is part why we're spending a lot of time on education, training, and trying to grow that infrastructure to bring better screening for the same exact purpose, to more individuals. This is now considered best practice in this consensus document published by FIFA on how we should screen youth soccer players. And even the American Heart Association and American College of Cardiology, in their most recent recommendations, recognize the additional value of an ECG when it can be appropriately implemented. And in this particular document, they recognize that a 12-lead ECG screening is reasonable as long as it has equitable access to the downstream process with appropriate resources. And although the history and physical has a relatively low, and they recognize that the history and physical has a relatively low sensitivity, 10 to 20%, and that ECG enhances detection up to 94% in their stated document. We had a whole workshop on ECG interpretation in athletes yesterday. I hope many of you were able to attend. And we have successfully lowered the false positive rate while maintaining the sensitivity to detect the conditions that we're looking for over the last couple of decades. There's been this evolution of different ECG interpretation standards, beginning with the European Society of Cardiology recommendations in 2010, the Seattle criteria, the refined criteria, and the international criteria published in 2017, all successfully lowering the false positive rate but maintaining our sensitivity. If you're not familiar with the international criteria, this is the published diagram from 2017, and I encourage you to go back to that workshop and understand its use and application. As you know, this past September, we hosted the International Summit on ECG Interpretation in Athletes right here in Seattle to update the international criteria. This is coming soon. This is a draft of that central figure. And again, I'm expecting publication hopefully in September of this year. If you begin advanced cardiovascular screening, you're going to start identifying athletes with conditions at risk for sudden cardiac arrest. And if you do, I encourage you to think about the ORCA study, the Outcomes Registry for Cardiac Conditions in Athletes. Anyone can refer an athlete through our website, our portal. Go to orcastudy.org for more information. I'm a big component, a big proponent of quality and advanced cardiovascular screening in athletes, but I also recognize that cardiovascular screening, no matter how we do it, is not perfect, and we have to be prepared for sudden cardiac arrest on the field of play. All of you are aware of what emergency preparedness includes: a written emergency action plan, staff awareness of where those AEDs are, trained responders in CPR and AED, immediate access to an AED within 3 minutes from collapse to first shock, review and rehearsal of that EAP at least annually, and now something called a pregame medical timeout or pregame medical meeting. For the Seahawks, we practice our EAP twice in the preseason, once at the practice facility, once at the stadium, with all potential responders, our team physicians, athletic trainers, paramedics, EMTs, and now really a third-party evaluator. And I do think that has elevated our practice sessions almost to like really to a simulation, very real life based with lots of good feedback. In the NFL, we've got the 60-minute pregame medical meeting where both sides come to one room, as well as all the venue specific medical staff. So we've got representation from the home team, visiting team, as well as the venue to just review quickly key components of that emergency action plan. That pregame medical timeout is now really at most universities and in the state of Washington a requirement at our high school games as well. So even if an athletic trainer is not there, some representative from each team, home and away, and one referee need to go over some basic information. If there's a medical emergency, who's leading the way, who's calling 911, where's the closest AED, if EMS does have to come to the venue, what's their entry route, who's meeting them, etc. I want to focus on survival from sudden cardiac arrest over the last 2 decades, and this is some of our early research published looking at survival trends following exercise-related sudden cardiac arrest in the young from 2000 to 2006. Almost 500 cases here, and you can see back then survival was pretty low, 11% overall, with a small uptick in 2004, 2005, and 2006, probably because the beginning presence of AEDs, at these venues. I had the opportunity to co-chair this consensus statement with Ron Corson, the Inter-Association Task Force Recommendations on Emergency Preparedness and Management of Sudden Cardiac Arrest in High School and College Athletic Programs. This was published in 2007, and we were able to interview several athletic trainers who had been present for cases of sudden cardiac arrest in an athlete. And what did we learn? We learned that recognition was the key barrier, that there was often a delay, 1 to 3 or even 4 minutes before someone actually recognized it was sudden cardiac arrest. And so we took a leap of faith in these recommendations to bypass some of the CPR guidelines, that if you had a collapsed and unresponsive athlete, you had to assume it was sudden cardiac arrest, call for help, start chest compressions, and get the AED. This was a study we published in 2013, a 2-year prospective observational study, 2,100 high schools across the U.S., largely with good emergency plans and AED programs. We monitored for all cases of sudden cardiac arrest on school grounds, looking at survival outcomes. So in that 2-year period, there were 59 cases, 71% overall survival. In adults on school campuses, 61% survival. And our students, 85% survival. And our student athletes, all with a witnessed sudden cardiac arrest during exercise, 89% survival. We've continued to monitor outcomes across the US, and this is more recent data looking at all comers of schools and exercise-related SCA in a high school student. You can see the continued sort of rise in survival rates, and in 2017-18, overall survival was 78%. But if you had an athletic trainer on site, if there was an on-site AED that was used, survival was above 80%. We can also learn a lot from our Japanese colleagues who have amazing emergency preparations at their endurance events and marathons, lots of bike rescuers, AEDs everywhere. In this particular study, 28 runners with witnessed SCA. Note when you got there early, there was gasping or continued respiratory movements in 89% of the individuals. CPR was performed in less than 1 minute. Time to AED shock about 2 minutes, 100% survival. So my message about sudden cardiac arrest in athletes is that it's largely a survivable event through prompt treatment and access to an AED. This is the universal response to a collapsed athlete that I support and recommend. Again, if you have someone who's collapsed and unresponsive, you have to assume it's sudden cardiac arrest. By unresponsive, I mean unresponsive to a shoulder tap and verbal stimuli, and then start your emergency response. Call 911, start chest compressions, someone go retrieve and apply the AED as soon as possible. And beware of the signs in the red box, the features of sudden cardiac arrest that can really misdirect us in terms of what the cause of this collapse is. Continued respirations, seizure-like activity, the eyes are usually open or open and rolled back, or perhaps even falsely assuming the presence of a pulse. If we just go back to research over the last couple decades where survival was at first very low, the consensus statement in 2007, some additional research where survival started to just improve, updated consensus statement, more survival outcomes research. If we take a couple of those data points from 2006, let's say 21% overall survival, to 2018, 78% overall survival from exercise-related SCA, that's about a 270% improvement in sudden cardiac arrest survival. So there's debate still about how we should do cardiovascular screening in athletes. There is no debate on emergency preparedness and access to AEDs, but we have to be able to recognize when to use those. This was a nice editorial published in 2019 in BJSM, looking at some of the features of sudden cardiac arrest in an athlete. In young athletes, it's almost always ventricular fibrillation or rapid VT. They may collapse immediately, or they may stumble or sway or put their hands on their knees and then collapse. Almost all of them have ongoing respiratory movements after collapse. About a third to half of them have some seizure-like activity, and their eyes are usually open with a fixed gaze or open and rolled back. I want to show you a video, a real-life compilation of how to recognize sudden cardiac arrest in an athlete. This is freely available on YouTube. You can use the QR code. Please use this in your training sessions with coaches, with parents, with your colleagues. Really, everyone responsible for the care of athletes on the field of play should understand how to recognize sudden cardiac arrest in an athlete. Hi everyone, I'm John Drezner, Director of the UW Medicine Center for Sports Cardiology, and in the next 100 seconds I want to show you how to recognize sudden cardiac arrest in an athlete.
He can be seen coming out of a timeout huddle, his head dropping. He stumbles, then alarmingly he falls face first.
Here you see Keontae head drop, stumble, sudden collapse. This is what sudden cardiac arrest in an athlete looks like.
And collapses, just like Hamlin did, in sports from football to lacrosse to baseball.
In Mark Vivian Foe, he shows all the signs of sudden cardiac arrest: continued breathing after collapse, eyes open and rolled back, the face of sudden cardiac arrest. For Damar, after his arrest, his arms go up with seizure-like activity. And for Christian Eriksen, a sudden collapse, also unresponsive, eyes open, brief seizure activity in his leg. This is sudden cardiac arrest.
We've been there, but that's not a good look at all.
With Claire, dramatic episode, collapse with seizure-like activity in the arms, an amazing emergency response. Call for help, someone go get the AED. Remember, in a collapsed athlete that is unresponsive to verbal stimuli and a shoulder tap, you must assume it's sudden cardiac arrest. Call for help, start chest compressions, get the AED. Anyone can save a life. Hi, everyone. I want to talk a little bit more about the last case in that video of Claire Crawford, who had her arrest at a high school volleyball game in 2015. This is the single best response to a collapsed athlete that I've seen. And it didn't occur at an NFL stadium with 30 medical professionals. It occurred in a high school gymnasium with a single athletic trainer and a very well-rehearsed emergency action plan that they practice twice a year. The first people out of the stands are actually her parents, then an administrator and the athletic trainer. They call 911 quickly. There's an AED by her side in about 30 seconds. CPR started within a minute. Defibrillation at 2 minutes and 20 seconds, which is about the same as defibrillation for Fabrice Muamba, and actually faster than when defibrillation occurred for Christian Eriksen or Damar Hamlin. In 2025, we published this study looking at sports-related SCA, a video analysis of presenting features, management, and outcomes. We looked at every video available, looking at the presenting features and signs of sudden cardiac arrest. For pre-collapse behavior, there often was a short amount of stumbling or swaying or even stopping and putting hands on knees before collapse. For the eyes, we could not see the face in every video, but in 100% of the videos where we could see the face, the eyes were open with a fixed gaze or eyes open and rolled back. Same thing for the chest. For breathing movements, we could not see the chest in every video, but in 100% of cases where we could see the chest, there were ongoing respiratory movements. And then seizure-like activity, again, about a third of them to maybe half of them had some seizure-like activity that could be gross tonic-clonic activity or even just shaking and quivering of a single limb. These features and signs of SCA are now part of Resuscitation Council UK guidelines on resuscitation on the field of play. This is a nice document that was published in 2024 and good resources. To take this a step further, I also like to talk with my paramedics and just remind them just some quick pearls about what to do, because as a physician, we're not always there when they might go ahead and come across a case of sudden cardiac arrest in a young athlete. I think they need to remember that seizure in someone who's been exercising, they need to think about that this is SCA. If this is an exercise-related collapse and the person's unresponsive, they have to think this is SCA. If it's a young athlete, this is almost always VFib arrest. Again, think SCA. They should resuscitate in place on the field or court until it seems more beneficial to pick up and move to the ambulance. So that usually is 2 to 3 rounds of defibrillation if needed, establishing a secure airway, IV medications, etc., before you're sort of packaging to get in the rig. If standard lead placement does not lead to return of spontaneous circulation after 2 attempts at defibrillation, they could consider changing to an anterior-posterior lead placement. And then again, if you still don't have ROSC and you're transferring someone who needs CPR, using automated CPR machines or a Lucas device in that transfer and transport may be beneficial. So where are the gaps still to improving survival? And I like to show this picture. These are 4 cases of sudden cardiac arrest in a young athlete that all occurred in May of 2018. And I can sort of ask you, think to yourself, what's similar about these 4 cases? Yes, they're all young, male, Black basketball players, our highest risk demographic. But what I wanted to show is that actually all four of these cases occurred at non-school sponsored events. We studied this. We looked at our highest risk sport, male basketball players at high school, middle school, and compared survival if that was a school-based event versus like an AAU-based event. If it was a school-based event, survival was twice as high, bystander CPR twice as high, and AED use more than twice as high if this was a school-sponsored event. So at our community-sponsored events, the emergency preparedness just isn't there. My son plays basketball, and this is one of those big, weekend event centers, probably 10 to 12 basketball courts. The first time we were there, I got there and sort of walked the perimeter as I always do. Where's that AED? I walked one direction, I couldn't find it. I turned around, walked the other direction, and there it was, sort of hidden behind, the vending machine with absolutely no signage. And I guarantee that not a single person who was an event organizer knew where that AED was if there was an emergency. This year, our sports medicine fellow, Nicole Leonard, and one of our residents, Muriel Lavallee, have done a wonderful project looking at socioeconomic disadvantage and survival from exercise-related SCA in U.S. middle and high school athletes. We divided the cases, into school-based and community-based, and you can see that school-based survival was 61%, community-based survival only 40%. This is a 35% less likelihood to survive if this was a community-based athletic event. So lots of work to be done. We also looked at this sort of neighborhood or community level of socioeconomic disadvantage using two different indices, the area deprivation index and the social vulnerability index. And while survival appeared lower when there was greater socioeconomic disadvantage, these differences were not statistically significant. In the Seattle and really Washington area, we have something called Project 100, which is really a multi-stakeholder initiative to put AEDs outside where people play sports or recreate. Project 100, the 100 is somewhat aspirational. We want 100% of our fields and facilities with AEDs. We want 100% access to AEDs. We want 100% survival. We want defibrillation in 100 seconds. We want 100% of coaches, trained in CPR. This has really been a nice community initiative that is taking hold, where we are getting AEDs in environmentally protected cabinets, outdoors and established where young kids and adults are exercising. I want to end with just some comments on whether or not we have this right on recognition of sudden cardiac arrest, and specifically to talk about the 2025 American Heart Association CPR and emergency cardiovascular care guidelines. This is a massive undertaking to update these guidelines. They look at all the evidence, etc. In this particular guideline, they expand, the chain of survival, really beginning appropriately with this recognition, of the event. But do we have it right? And so, reading the recommendations here for a lay responder, if an adult is unconscious, unresponsive, with absent or abnormal breathing, i.e., only gasping, the lay rescuer should assume the person is in cardiac arrest. What lay responder is going to be able to tell the difference between normal and abnormal breathing when you've seen that all of these athletes have continued chest movements or perhaps gasping? This does not need to be part of our recognition algorithm, and I think it shouldn't be there. Again, collapsed and unresponsive, begin your emergency procedures. Same thing for health professionals. If we read the recommendation, it's to check a pulse. Again, I don't think this has to be there, just collapsed and unresponsive. Let's walk through this, right? So let's say you check a pulse. If there's no pulse, well, clearly you're going to start CPR and get the AED. But what if there is a pulse? Are you so confident that you're not going to put on the AED if that person stays unresponsive? So either way, you're getting the AED and you're putting on the pads as soon as possible. I looked at the whole 85-page document. I searched for the term seizure. It's not presented in the document even once, until the post-cardiac arrest care that is occurring in the hospital. So seizure is this common thing when you call 911 and someone has seen an athlete with SCA, they often call and say, someone's having a seizure. I think 911 needs to change how they respond to that if they know this is exercise related. Has the seizure stopped? If the seizure stopped, are they awake or are they still unresponsive? If they're still unresponsive, start CPR and ask if an AED is close by. I also searched the document for the word exercise, and the word exercise is not included even once in this document. So again, hopefully future guidelines we can be better in terms of how we recognize exercise-related SCA. And it's not just airway, breathing, circulation. It really needs to start with better recognition. So in conclusion, prevention of sudden cardiac death in athletes requires both advanced cardiovascular screening and emergency preparedness. Learn the international criteria if you're going to use ECG for your cardiovascular screening. Understand how to recognize sudden cardiac arrest in athletes and advocate for AEDs everywhere. Thank you very much for your attention and look forward to some questions in the question and answer period. Thank you.